Good afternoon, everybody, and thank you for the honor and privilege of being here, and also to all of you who have been here for 2 full days. It's been an incredibly exciting conference, but I also recognize that you are about an hour away from the end. And I think Dr. Carl and I are the only ones standing between you and that. So thank you for staying here with us. Let me see. There we go. So I want to begin by just reviewing a little bit about the situation in the United States when we turned the last century, which was about 2000, and begin to put into perspective what we were facing in American medicine. We had a number of challenges. First of all, we had what some have termed the longevity revolution, which others, I gather around here, have been terming the silver tsunami. Either way, we have an unprecedented gain in life expectancy, in which the average adult can now expect to live somewhere between 78 to 82 years, depending on if you're in the United States or in Singapore. And with that increase in longevity, a tremendous rise in the numbers of frail older adults who are in our population and for whom we are going to be taking care of. We've seen the cause of death shift from really in the last 100 years from sudden illness where somebody would get an infection and without antibiotics would die within 48, 72 hours to where overwhelmingly people die of chronic episodic disease over a period of years and years. We have a lot of data that demonstrates that people with serious illness live with untreated physical symptoms, untreated psychological symptoms, tremendous needs of their families which are not being met. Inadequately trained healthcare professionals. I spent 4 years at one of the best medical schools in the United States. If you go to the University of Chicago, they will tell you that it is the best school in the United States. Another 3 years at actually a quite good residency program. Another 3 years doing a geriatric fellowship, and throughout that 10 years of medical education, had a 30-minute lecture in pain management, which dealt with how opioids are metabolized in the liver and excreted in the kidney. It happened in my first-year pharmacology course. And when I'm sitting at the bedside of a patient, recalling that information is not terribly helpful in treating their pain. And that has been the norm in terms of medical education. And we had and have in the United States a relatively unresponsive healthcare system which is facing enormous expenditures, largely because of the growth of seriously ill patients. When we look at Medicare spending, which is the insurance for people over the age of 65, 5% of Medicare enrollees, that is the most seriously ill, account for 53% of spending. And if we drill down even further, 1% accounts for over 24% of Medicare spending. So we are, in many respects, going bankrupt because of the population that we're taking care of. So one of the things I wanted to talk to all of you today is to give you an example of how we can engage research to advance clinical practice, and use the example of 2 organizations I've been very privileged to be a part of, one of which is one I direct, which is called the National Palliative Care Research Center, which is focused on enhancing the evidence base of palliative care. And the other is the Center to Advance Palliative Care, which my colleague and friend Diane Meyer directs, which is really focused on translating research into effective practice. And I want to talk to you a little bit about the work of our 2 organizations and sort of the challenges that we faced. We have a collaborative vision, and our collaborative vision is essentially that by 2020, all patients with serious illness and their families will have access to high-quality palliative care throughout the disease course and across settings throughout the United States. And we think we will get there by 3 key ways. First is all patients and families will know how to request palliative care, that medical professionals will have the knowledge and skills to provide it. Now, that doesn't necessarily mean that we're all going to be palliative care specialists. What it does mean is that palliative care will be integrated through primary care all the way up to specialist level care. And that thirdly, all of our healthcare institutions will be able to provide that across the care continuum, from hospitals to long-term care to home to rehabilitation. And I think we will get there. So let me tell you about the 2 organizations. They're relatively unique. The one I direct is funded by 10 philanthropic organizations throughout the United States. It's funded by charity. We have a specific audience, and the audience is academic institutions, researchers, and policymakers. That's who we answer to, and we're very focused and directed at that. And the focus of the center is the development of a palliative care evidence base and a research infrastructure. And we have a couple of products. We fund pilot exploratory grants for mid-career investigators so that they can be leveraged into larger research dollars. We work at developing a cohort of junior faculty and junior investigators to actually build the field. And we hope to provide, and do provide, a lot of technical assistance to help researchers. For example, how do you write a grant? How do you get it funded? Can it be reviewed? Do you need statistical consultation? And we do that for our community throughout the United States. And we also work on developing a community of researchers by funding a conference and retreat to bring people like this together. The other center is a Center of Advanced Palliative Care. It's also funded by philanthropy, 12 organizations, some of which overlap with mine. CAPC has a very different audience. Their audience is not academicians. Their audience is hospitals and health systems, clinicians, and policymakers, with the idea that this is the audience that is going to integrate palliative care into the continuum of care. The focus of CAPC is different. It's the dissemination of the palliative care evidence base to hospitals and health systems in a way that it can be integrated rapidly into practice so that nobody has to reinvent a wheel. And the products here are really, it's a diversified portfolio of practical technical assistance products. It's business plans, it's marketing materials, it's seminars, it's web-based learning, it's leadership centers where you can come to learn how to develop a palliative care team. So let me talk a little bit about the guiding principles behind this, because I think this does translate across different cultures and institutions. And I think the first thing that we learned very early on, which has contributed to the success and the growth of palliative care in the United States, is we are not the audience. Let me give you an example. Throughout the course of time here today, within our audience, within everybody who shares our vision, the discussion has been about improving care at the end of life, improving care of the dying. We've talked about palliative care in the setting of life-limiting illness. Let me tell you, folks, that is not what our patients and families want to hear. Let me give you some examples. Let's go back to Homer, okay? Homer didn't like death very much. Better to flee from death than feel its grip. Shakespeare wasn't a big fan of it either. The weariest and most loathed worldly life that age, ache, penury, and imprisonment can lay on nature is a paradise to what we fear of death. Woody Allen, I don't want to achieve immortality through my work. I'd rather achieve it by not dying. If we continue to sell ourselves to our patients, to our families, as somebody who is going to make their death better, I would suggest to you, as my marketing colleagues say, we are selling a product that nobody really wants to buy. And this key principle about targeting and knowing our audience was something that was incredibly hard for all of us at CAPS and the MPCRC to get our brains around and learn. But it has been instrumental to our success, as I'll talk about in a minute. So the fundamental shift for us was changing the message from improving care to the dying to improving quality of life for people living with serious illness. We had two other guiding principles. The second was that the responsibility of a publicly funded researcher doesn't end with the publication. That if we are accepting taxpayer dollars to do research, our responsibility didn't end when we published. That it was our responsibility to our society was to do more. And, you know, if I publish in the New England Journal of Medicine, that is fantastic. My colleagues will see it. You know, my students may see it. My father will only see it if I tell him about it. Nobody else is going to see it or be impressed by that. So policymakers and the public folks don't read the medical journals. So that creating change requires audience-specific messaging. It requires the effective use of the media, and it requires technical assistance. It is something that we are incredibly uncomfortable thinking about as academics. And as Admiral Hyman Rickover, who is sort of the father of the American nuclear navy, said, good ideas are not adopted automatically. They must be driven into practice. It's not enough to have a good idea. Palliative care is a brilliant idea. It addresses so many of our patients' needs, our families' needs, and the needs of healthcare professionals. But if you are working in a system that has cost pressures and cost containment, a good idea is not going to be adopted unless it has a sound business case behind it. Because in our current healthcare environment, there are a lot of good ideas. And there are a lot of things that potentially will do very good for people, but unless they have a sound business case behind them, they're not going to be rapidly integrated and taken up within a healthcare system. So we have had, over the course of the past 5 to 10 years, 2 specific strategies, and I'm going to give you 3 examples of how these play out. The first is a top-down strategy. That is, we begin with formalizing activities. So at a very sort of top-heavy level, we think about creating a supportive environment via the media, accreditation, policy, regulations, payers, research, and education, essentially to provide the supportive platform, while at the same time, we have a bottom-up approach, which is the core activities such as research, improving the evidence base, technical assistance, developing programs at individual hospitals, developing independent studies and original studies. And each of these activities reinforce themselves. So let me give you 3 examples over the course of our 10-year collaboration as to how this looks like in the real world and how we've used both research to drive clinical change and clinical practice, and indeed some policy change. So let me give you our first example. We had a policy goal. We wanted to think about how do you drive local demand for palliative care? How is it that within your communities you can increase, within hospitals, and hospitals was our example, how do you increase a hospital's willingness to develop a palliative care team? So we did some research. And we thought, you know what, Americans are incredibly competitive. You know, if somebody has something, somebody else wants something else. So we were interested in, you know, what was a statewide variation? What was the variation in access to palliative care across the United States? We wanted to look at what was access to palliative care clinical training, what were the factors associated with the development of palliative care teams. You know, this was very important information for us in terms of thinking about how are we going to grow the field and where we were going to target. Particularly for CAPSU, we wanted to know, you know, where were the programs and where were they not so we could target where they weren't. This is a collaboration between our 2 institutions and the American Hospital Associations. Led to a really nice paper from my medical student. It was published in the Journal of Palliative Medicine. It was called Variability in Access to Hospital Palliative Care in the United States. He went on to get a really nice fellowship program for this. This actually became the #1 cited paper in the journal the year it was published, which was really impressive for him. It was fantastic. But as I said, I think about 5 people in the real world read it. What do we do with that, though? We did a couple of things. First of all, we made a couple of products. I have 15 minutes left. I'm going to give you grief the whole time. So what did we do? Well, we made a report card. We made a report card where we actually ranked all the various states from A to F. And I'll show you the inside of that. And what did we do with that? We put it on the desk of every single senator and congressperson in the U.S. Senate and House of Representatives, and we mailed it to the individual state governors. We took a full-page ad out in Politico, which is the major newspaper that sits in Washington, and identified the team, the groups that were doing it, and I had this great experience of, you have to understand the U.S. Senate. The U.S. Senate is so big, there's a little underground trolley that runs from one building to the other. So I'm in the trolley with Senator Whitehouse of Rhode Island, riding across after meeting with him. And Senator Bernie Sanders of Vermont, down here, is in the other car behind him. You can't talk because of the glass. And White House is holding up this ad in his window to Sanders in the back, pointing at the two states. This had a huge impact in terms of recognition of palliative care, and in fact, put it up on our website, and you can actually go in and figure out how your state compares and indeed how your country compares. Oklahoma got an F the first time we did this with 0 palliative care programs. They actually spent a huge amount of money to develop it after that. We pushed this to the news, and we wrote stories for people in local newspapers so that the message got out pretty quickly. This is just an example of all the stories that came out. Where's the one that I like? Alabama gets a D, but UAB is way above the curve. So even Birmingham takes credit for something that... but we hit over 10 million people throughout the United States with a message about your program needs, your community needs palliative care. Second goal, okay? We recognized that we needed a business case for palliative care, that it wasn't going to happen unless there was a sound business case. So the research here that we wanted to do was we wanted to look at, could we identify and quantify cost savings associated with palliative care? That is, does palliative care in the setting of serious illness at least reduce costs? Actually, my hypothesis was it was going to be cost neutral. I actually thought that if we could demonstrate cost neutrality, that would be fine, at least demonstrate it wasn't costing more. We used some sort of wonky economic principles to actually get at that, propensity score, instrumental variables. We wanted actually to provide some national normative cost data for hospitals, because what we were getting from people was, how much can I expect to save? Or is this going to cost us more money? And we wanted to look across different systems of care, because the 3 big payers in the United States were Medicare, Medicaid, and the VA, which is our only form of integrated capitated health care. We published 3 papers. This was actually the biggest and the best. This was an 8-hospital site across the United States. Lots of cost savings. This is the VA paper. And actually, this is the one we did most recently that looked at Medicaid findings and savings to Medicaid, which takes care of our indigent population. We got some nice pretty graphs on it, but basically this is the day of palliative care consultation for those of you who'd like to see some data. The red bar, or the light blue bars are people who receive palliative care up until the day of consultation. This is after consultation. The usual care group is matched by propensity score based upon a reference day. You can look at this. You can see that their costs are exactly the same until the day of consultation, in which case palliative care costs go way down, and indeed usual care costs stay up. And the black line is the regression line of the usual care patients, or the palliative care patients, which was plotted out, projected out afterwards. And you can see that they look almost exactly the same. That again made some nice medical journals. A couple more people read that. But what we did was we turned this into a very slick brochure with, you notice here are the main findings. Notice how few words there are. This was actually marketed to hospital CEOs and CFOs, and again was put on the desk of every single major hospital CFO and CEO, because you can read it in about 30 seconds. We also took that and made that into strategic planning tools. So you can go to our website and download the cost avoidance calculator, so you can put numbers in for your institution so that you can get your own savings. Impact calculator, Medicare billing. Basically what it did is we took our data and made it super easy for you to do the same thing for your hospital without having a healthcare economist as a partner, so that you could run the numbers and make it very easy to develop a sound business case for your palliative care program. Again, no reinvention of the wheel. And this, we had a very different media outreach strategy. Whereas the other one, we wanted to let the world know, we did not want to let the world know here. We did not want the message that saving money for the seriously ill is a good thing. That's probably not a great thing to say, that we're going to be cutting dollars on our most seriously and vulnerable patients. So who do we target? We target the business news. So we made a very conscious effort to go after Cranes, to go after Forbes, to go after the business section of U.S. News. We blew it. We got into Modern Healthcare and Reuters. And we got into Politico, which was our policymakers, because we got it out at the policymakers. And again, a lot of attention, but not nearly as much as the other studies. So what was the outcome of developing a really sound business case and making it? Well, with everything that was going on in healthcare in the United States, part of the big issue was that if you develop a sound business case and match it to improved quality, you can see dramatic growth. So back in 2000, when we started, there were just a little over 600 hospitals in the United States who had a palliative care team. Most recent data, which was the 2011 American Hospital Association survey, showed that that number was now over 1,400. So that 2/3 of all hospitals and over 85% of our mid to large size hospitals now are reporting a palliative care team. The Joint Commission has a certification program. Why do they have it now? Because there are enough hospitals that actually have programs that the Joint Commission can make money by having a certificate program. Don't laugh at me, folks. That was when we went to them and said, can we have an advanced certification? They said, we need to have a business case for it. Are there enough hospitals to buy it? Yeah, there are. And what was really very interesting and very neat was that when the Health Affairs study was published, it timed exactly with when New York State was redoing their Medicaid plan. They were recognizing that Medicaid was going bankrupt. And as that was published, they were redoing Medicaid. And the result was that after we testified before the Medicaid Commission, we got the Palliative Care Information Act, which amends the public health law requiring physicians and nurse practitioners to tell terminally ill patients about their options concerning palliative care, and more importantly, requires every institution in New York State that receives state dollars, Medicaid dollars, which by the way is every single one, to provide access to palliative care. We are now working on telling them how they can actually implement that. And then finally, I want to talk a little bit about creating the supportive environment. So what I've done is, we've talked a little bit about, sorry, I'm going to go back quickly. Top down, creating the policy case, bottom up, business case. We cycle back now to top down in legislation, okay? Because now we've created a supportive environment. Now we're thinking about what are the policy changes that we can have. And our policy goal is really pretty straightforward. Can we create funding for research that will enhance the evidence base in palliative care? And can we demonstrate public demand for this care? How many of you remember the death panel fiasco? Did that make it over here? Yeah, right? What was the problem with the death panel fiasco? It was all about advanced care planning. As the Newsweek cover said, the case for killing Granny. That has been a huge barrier to getting effective palliative care legislation move forward in the United States because of politicians' worries about being linked to the death panel. So we decided that we needed to do some research to give politicians some cover. So what did we want to do? We wanted to understand, public understanding of what palliative care was. We wanted to develop a patient-centered definition, and Professor Tulsky talked a little bit about that definition yesterday. It seems like ages ago, but it was only yesterday morning. And we wanted to report on public support for palliative care. We wanted to know, what does the general public think about our field? So what did we do? We did some research. We did some physician focus groups. I'm not going to talk about the results from that. I'm happy to do so if you want. And then we did a very large telephone survey after we developed a questionnaire of over 800 Americans, and we oversampled for those over age 65. We wanted to do market research on wording of the definition. That is, we all know what palliative care does, right? We all know what it delivers. But what we wanted to know was, what does the general public want to hear, and what is going to resonate with them? Because we know what they don't want to hear. We've got lots of experience that say that they don't want to hear about a peaceful death. But what is it that they want to hear that will integrate palliative care into the care of people with serious illness? We wanted to know about people's perceptions about the role of palliative care in the setting of a serious illness. Is this something that people really want? And finally, we wanted to get a measure of support for palliative care. And this was, I wish I could take credit for this, and I can't, because it was my consultant who did it. But we worked really hard to develop the survey. And we could have actually administrated it. You know, we've done survey research before. But what our consultant suggested was, you know, you guys shouldn't be doing it. So what we did was we actually farmed it out to Public Opinion Strategies, which is the most well-respected Republican polling firm in Washington. Because we knew that the considerable objections and the death panel rhetoric came from the far right in the United States. So what we did is we worked with a very well-respected, relatively right-wing polling firm to do the data so that we could go forward, and we weren't worried about the Democratic Party. They were going to be on board. We were worried about the Republican Party. So we got POS to do it. Actually, we paid them to do it. So what did we find? Well, what we found is, you know what? The focus groups, but I'm going to actually start with the public. What we found is the public has absolutely no idea what palliative care is in the United States. 70% said they had absolutely no idea what it was. 14% said that they were somewhat knowledgeable. And if we look at this, only 8% that they said they were knowledgeable or very knowledgeable. So this idea about saying to somebody, what is palliative care? People have no idea what you're talking about. That, folks, presents an opportunity because you can begin to define it the way that resonates with your audience. By the way, the focus groups, which I don't have data on, the physicians all said they knew what palliative care was, and they were all wrong. So the big barrier, the physicians are, this is something you do when nothing else is working, was the main message that we got. We did a lot of work, and I'm not going to redo, actually I'm going to say it, I actually have it in a minute, but Professor Tulsky gave you the definition, but that was done after a lot of work getting the right words and asking people what words make sense to them, what do they understand about it. And when we got to the definition that Professor Tulsky gave, we found that 95% of respondents believe that patients with their serious illness and their families should be educated about palliative care. Over 90% said they wanted it for them or one of their loved ones. And over 90% said that it should be available across all hospitals. And that ranged from very liberal Democrats to Tea Party Republicans. There was absolutely no difference in endorsement across the political spectrum. And we asked people about their political bent. Why is that important? I'm going to skip this. Actually, I'm not. So this was the product. This was the definition. Remember, this is what James gave you yesterday. Focuses on relieving symptoms, pain, and stress of a serious illness. I've got 1 minute, huh? Okay. Improves quality of life. Provided by a team. This was critical. Everybody we talked to, patients and families, loved the idea of the extra or added layer of support. And appropriate at any stage and can be provided with curative treatment. So that was sort of the, you know, academic definition. Let me show you the public definition. This is the ad that the American Cancer Society is running in all major journals now and in the major newspapers and in Washington. Cancer becomes a dancer. What you can't read down here is this is the palliative care definition that I just showed you there. So this is an ad for palliative care, which is running in Politico and all the major major newspapers in Washington. Why is it running? Because at the bottom here, which you can't really read, it says support palliative care legislation, House and Senate bills, bring quality of life and care together for the millions facing cancer. So what happens after we got the definition and we got cover for legislators so that they could go forward and actually do something? We got 2 bills introduced into the House and Senate. First is the Patient-Centered Quality of Life Act, expands research necessary to establish a strong science base for palliative care. So this calls for research funding in palliative care. And workforce initiatives. That's the first one. Second is a bill that we have been working on for years, which is creating incentives to improve training and retraining of health professionals, creating palliative care centers of excellence, and then grants or contracts for health professionals to teach palliative care for 5 years, which for 3 years we had one sponsor on. You know, a Democratic senator from Oregon. With all this work and putting it forward, we now have bipartisan sponsorship, Republicans and Democrats, and an additional now, at last count, 25 co-signatures on it. Huge, huge difference. Again, because data supported the fact that this was okay. I'm going to stop there. Say thank you very much.